Nasogastric tubes, or NG tubes for short, are tubes that enter the patient through the nose and extend into the stomach. They can be used post-surgically to reduce risk of vomiting. They can allow access to gastric contents for analysis. They can provide a method of performing gastric lavage, or they can allow a route of administration for medications, or nutrients through tube feeding. These devices are commonly placed by the nursing staff. Successful placement can be tricky, but many times the biggest hurdle to overcome is that it can be a very uncomfortable and sometimes painful procedure for the patient, which can make things very difficult for the person performing the placement. The process of placing an NG tube can be demonstrated on a manikin, and in this video, the steps of placement will be explained and demonstrated this way. Knowing the steps will get you most of the way there. Troubleshooting and tips and tricks are better demonstrated on a real person, and you can view this in a separate video where I try them all to successfully place an NG tube on myself. This video will focus on the required steps to successful placement of an NG tube. Let's start with the basics. An NG tube is inserted into one of the nares, travels along the base of the nasal canal, turning at the nasopharynx and traveling down to reach the esophagus, and then down further until it reaches the stomach. At Trinity Health Livonia, the NG tubes available in the pod rooms are barred NG sump tubes with Prevent anti-reflux filters. They are readily supplied in 14 French, 16 French, and 18 French sizes. With French sizing, the smaller the number, the smaller the tube, so a 14 French is the smallest of the three. The end of the NG tube that will sit in the stomach has multiple openings to allow flow into and out of the tube. There is a radiopaque strip embedded in the tube to allow for visualization of the device via X-ray. There are also markings indicating distance of the tube. The first black dot represents 18 inches, then 22 inches, then 26, and then 30 inches from the distal end of the tube. That's the end sitting in the stomach. The proximal end of a Salem sump design, like the one used in this video, has two openings. The first is the large opening at the end of the clear tube. This allows access to the end sitting in the stomach with all the holes that we already looked at. It is how you will deliver treatment, or remove gastric contents via suction. The plug that is inserted into this tube is an adapter that allows you to connect the NG tube to suction tubing, if suction is ordered. The other opening is a small blue pigtail with a filter inserted into the end. This tube allows environmental air to pass freely into the tube and into the stomach to prevent the formation of a vacuum if suction is applied to the NG tube. The filter on the end of the pigtail is an anti-reflux filter to ensure gastric contents aren't able to exit the NG tube through this opening. Attached to this filter is another small plug. This can be used to plug or cap off the main opening of the NG tube if necessary. Now that we know the device, let's take a look at the other supplies you'll need in order to place an NG tube. You'll need to determine the appropriate size of the NG tube. It may be in the physician order, or you may need to choose. And there are many factors that will determine appropriate size, but always take into account the size of the patient's nare and the purpose of the NG tube, and that will give you a place to start when determining if you need a smaller or larger tube. You'll also need a pair of gloves, a catheter-tip syringe, lubrication, something to secure the tube to the patient's nose. At Trinity Livonia, we commonly utilize the H-shaped band-aids, but there are also devices available specifically designed for securing NG tubes, or you can use the split tape method. You'll also need some tape, a safety pin, a stethoscope, an emesis basin, and a procedural pad. Optionally, you may also want to have a pen light, a permanent marker, more extensive PPE, such as a mask or eye protection. I have placed many NG tubes in my career, and being on the receiving end of projectiles from coughing or vomiting is bound to happen to you eventually, so I highly recommend the added PPE. If it is safe for the patient to swallow, you will want a cup of water with a straw for the patient to drink as you place the tube. You may also find you need a cup of ice water or warm water to manipulate the tubing in some cases. And if suction is ordered, you will need to ensure your suction is set up appropriately. Now we will walk through the steps of performing an insertion, and we will utilize the medical manikin for this demonstration. Before you set anything up, explain the procedure to the patient. They need to be prepared for what is about to happen, and as I've stated, this is not a pleasant experience. Make sure to tell them what you are going to do, and importantly, why they need this device. After watching this video, I think you will be prepared to give a thorough and appropriate explanation. After explaining the procedure, assess the patient. Sit the patient upright, as high as they can tolerate. If sitting up is contraindicated for the patient for some reason, consider a reverse Trendelenburg position. Assess the patient to decide which nair you will use. You can use a pen light to look into the nose and see if you identify any septal defects, but you may not know how to identify those anyway. At the very least, ask the patient if they can breathe better through one side of their nose. Have them plug each side separately and breathe through the open nair. Listen to their breathing. Does one side sound more strained than the other? Then look into their nairs for general size. Nairs aren't actually identical. Inserting into the larger nair will be easier. Clearer breathing implies a clearer nasal canal, which means less resistance. Choose the nair that gives you the easiest insertion. For me, I was breathing well through each side, but my left nair is larger than my right, so I would choose to insert into the left side. Now prepare your supplies. Note that NG tube placement is not a sterile procedure. The GI tract is not a sterile environment, so the procedure cannot be sterile. That being said, we do always strive to perform tasks as aseptically as possible. So begin by performing hand hygiene and don your clean gloves. Then open the NG tube. You need to measure the distance from the nose to the stomach. Do this by taking the tip of the NG tube and holding it at the tip of the patient's nose. Stretch the tube to the patient's earlobe, and then from the earlobe to the xiphoid process. Many sources tell you to stop measuring at this point, and many others tell you to continue a bit further, either saying, add X amount of inches or centimeters, or, and then continue halfway to the umbilicus. Conflicting information is frustrating, but what it comes down to is generally that it is safer to have a little extra length than not enough. So when I placed my own tube, I extended the measurement from the xiphoid process to halfway to the umbilicus, and found success with this length. Once you have the measurement, mark it. You can use a permanent marker to draw a line at the correct measurement, or you can use a piece of tape to mark the length. I prefer the tape method because I find it easy to lose sight of the marking while inserting, but the tape ensures you'll stop at the right distance. You can coil the first 8 inches or so around your hand to give the tip of the tubing a bit of a curve, and the heat from your hand will help the tube gain some flexibility. Heavily lubricate the end of the NG tube. Place the procedural pad over the patient like a bib, and either give the patient the emesis basin or keep it close by. If the patient is able to swallow, have a cup of water with a straw ready. But this isn't necessary for insertion. It can just make it a little easier. This will be unpleasant for the patient. They will feel a lot of pressure in the back of their nose at first, and then they will have to contend with their gag reflex. Many patients will not be able to resist fighting the insertion, so you may need to gently support the back of their head with one hand so they can't easily pull away from you. When you begin the insertion, insert along the floor of the nasal canal. Many times I have seen people want to insert with an angle going up the nose, but this angle will not allow the tube to reach the nasopharynx, and you will meet resistance very early. Keep the tube flat on the floor of the nasal canal. If your tube has a noticeable curve from when you curled it around your hand, the curve should be pointed down. Insert until you reach the back of the nasal canal. You'll likely get to a point of slight resistance. You may feel a slight release as the tube moves into the nasopharynx, or you may have to provide steady pressure to push through this point. This will be an unpleasant step for the patient. As soon as you're past this point, the tube will turn down the pharynx toward the esophagus. I usually refer to this as making the turn. After you've made the turn, you want the patient to lower their chin to their chest. This will help line up the esophagus with the pharynx, making it easier to advance properly. And it will pinch the trachea shut slightly, making it a smaller target, which makes it less likely that you accidentally insert the NG tube into the trachea and ultimately advance into the lung. With the patient's chin on their chest, you want to advance the tube quickly. If they are able to swallow, take the cup of water and bring the straw to their lips. Instruct them to swallow the water, and as they swallow, quickly advance the tube. Have the patient continue to drink, and as they drink, continue to quickly feed the tube in. They are swallowing water, but in essence, they are swallowing the tube into their stomach as well. When you reach the point you marked on the tube, stop the insertion. After inserting, you need to secure the NG tube in place. Clean the skin with an alcohol prep pad, and consider using a skin prep wipe as well. We often use the H-shaped Band-Aid. Put one half over the nose, and use the remaining 2 ends to wrap around the NG tube, securing it to the nose. If you marked the length with tape, remove the tape at this point. If you are using tape to secure to the nose, tear off a length of tape and split it down the middle for half of the length. Attach the intact half of tape to the patient's nose, and wrap the remaining 2 ends around the tube to secure it in place. Then take another length of tape, and further down the tube, create a tab of tape. Secure this to the gown using the safety pin. Make sure there is some slack between the pin and the nose. This will help prevent the tube from being accidentally pulled out. Now you need to verify placement, and you can do this in a number of ways. The first, easiest, and ultimately least reliable is to inject air into the tube and listen with your stethoscope for bubbling. If you hear bubbling, it means you are likely in the stomach. If you don't, it means you're likely not in the stomach. And that could mean you need more tube, or it could mean you ended up in the lungs instead of the stomach. We often use this method of verification to give us a good idea that we reached the stomach, but often we rely on more definitive methods before providing treatment through the device. If you have the supplies, you can perform a pH on the gastric fluid. Pull back on the syringe to remove some gastric fluid, then apply the fluid to a pH strip. A pH of less than 5 is indicative of proper placement. At Trinity Livonia, this method is rarely, if ever, used. The most reliable form of verification is to obtain a STAT chest X-ray. It can be performed at the bedside, so it is often ordered as a STAT portable chest X-ray. The X-ray will definitively verify proper placement of the tip of the NG tube, and you can confidently utilize it for treatment. Most practitioners will listen for bubbling to get a good idea if they were successful, and then utilize one of the more reliable tests to verify placement. With the tube secured and placement verified, you can now safely use the NG tube for treatment. That may mean setting it up to suction. It may mean setting up a tube feeding. And on the inpatient setting, it will commonly mean using it to administer medications. All medications must be thoroughly crushed and dissolved in water. You do not want to risk clogging the NG tube you just worked so hard to place. The larger the French, the larger the tube, and the less likely it will clog. Anytime you will be injecting medications or infusing tube feeding, make sure to flush the tube with at least 30 milliliters of water after use to ensure all meds or feeding are cleared from the tube and to prevent clogging. In some extreme cases, patients may need an NG tube placed, but for certain reasons, you cannot use the standard tubes available in the pod room. There are other products available. You may have heard of Dopov tubes, or Iris, or CoreTrack tubes. These are all brand names for different small-bore NG feeding tubes. At Trinity Livonia, these are only placed by specially trained personnel. Due to their extremely small size, extreme care must be taken when administering anything through the tube, or you risk clogging the tube. If you must administer medications through this tube, first, flush with 50 cc's of water. Then crush and completely dissolve the medication in water. There can be absolutely no sediment in that fluid. Some medications are not crushable. Other medications may not be able to dissolve completely, and in those cases, those meds cannot be delivered through this tube. But if you have successfully dissolved and administered medications, flush with another 50 cc's of water to ensure the tube is clear. When the NG tube is no longer needed, removal is a pretty straightforward process. Begin by removing the securement methods, the safety pin, and the Band-Aid or tape. Give the patient an emesis basin and put a procedure pad over their chest. Then have the patient take a deep breath and hold it. This closes the trachea and minimizes any risk of aspiration during removal. Then smoothly and quickly remove the tube. Those are the basic steps to inserting an NG tube. Understanding the process is pivotal to successful placement. But as stated earlier, not everyone will be as cooperative as the dummy was here. You'll likely run into some issues and barriers eventually, but don't let that deter you from trying. It's never going to be a pleasant and desirable experience for a patient, but with practice, you can improve your skills to make it as easy as possible for both you and your patient. To see a demonstration of some tips and tricks that I attempted on myself, please watch part 2 of the NG tube placement series.